Pericardial disease, pericarditis, pericardial disease. Now, the concepts I want you guys to know about pericarditis, pericardial disease are a few. I don't want you to know a lot of things, but the things I want you to know, I want you for definitely, for sure, to know about. Okay? So, pericardial disease, the most important thing about pericardial disease is for you to know what is the most important differential diagnosis. So when the patient comes in and you're worried about pericardial disease, what are you worried about the most? So you think if a patient has pericarditis, what do you worry about the most? So when the patient walks in, what's the presentation of pericarditis? Chest pain. So what's the most serious problem with chest pain? Myocardial infarction. So what you definitely want to do is to know whether this is just pericarditis or this is a myocardial infarction. Very two different things. Okay? So when we talk about pericarditis, things you see in pericarditis, so we can talk about, it's the space between the pericardial cavity, between the epicardium, visceral pericardium, and parietal pericardium. That's the pericardial space. We have about 25 to 50 cc's usually of fluids. So what I want to talk about here today is more about things. So what are the 5 differential diagnoses for chest pain? If a patient walks in emergency room, okay, with chest pain, what are the 5 causes that can kill him? Pulmonary embolism, aortic dissection. What's that? Yeah? Esophageal rupture, myocardial infarction, pneumothorax. Okay, those are the things that can kill the patient. Okay, what's the type of pain that you'll think this is myocardial infarction? What kind of pain is it? Chest pain, retrosternal chest pain, exertional in nature. Exertion. So acute coronary syndrome, so pain related to vessel occlusion is exertional. What makes you think about pericarditis? What's the most important thing to differentiate pericarditis from everything else? So, no, it's exactly what do you call that? No? Yeah, the leaning forward, what does that mean? I want one word to describe this stuff. Positional chest pain. Positional chest pain. Position, I don't care what's the position. Laying backward, forward, right, left, inspiration, I don't care. If the major thing about the chest pain is positional, this is pericarditis. Okay? What happens? The pericardium is in the middle of the chest. If you take inspiration, the lungs push. If you lean forward or backward, you can have increase or decrease. Now, the one that's written in the books is that when you lean forward, it's relieved. When you go backward, it's increased. As we know, diseases don't follow books. Okay? But there are general concepts we want to know. Positional is the most important one. So it's an inflammatory process that characterized by chest pain, and has a lot of etiologies. So what are the etiologies of pericarditis? What's the most common cause of pericarditis? So most common cause is
infection.
Idiopathic. 80% of the time it's idiopathic. Okay? But there are other causes. One, infection, viral. What else? Trauma. What's that?
Inflammation.
Acute inflammatory processes like connective tissue disease, amyloidosis, sarcoidosis, hypothyroidism, hyperthyroidism, a lot of things, right? So there's a lot of etiologies for pericarditis and secondary cause. Drugs, hydrazine, procainamide. So there's a lot of other ones. Okay. So specifically, when you have a patient who had a myocardial infarction, that's a specific type of pericarditis. So if somebody's rounding with me in CCU, the patient had an MI yesterday, stent. We opened the vessel with the angiograph and PCI as a stent. Today, you report to me in CCU, the patient has chest pain. How do I know the vessel, the stent didn't close again? What will he tell me?
Position.
So the patient tells you he has a chest pain that's positional in nature. So the chest pain is always there, not increasing, we're not changing or anything, or he notices it getting worse when he walks to the bathroom, that's probably another MI, or restenosis, or stent thrombosis, or stent dissection, or a lot of other things. But when you tell me this patient has chest pain, when he takes inspiration increases, when he's trying to lay down, change his position, it decreases or changes in character, then it's pericarditis. How do you treat it? In the setting of pericarditis, acute myocardial infarction. What do you give him? Do you give him NSAIDs?
No.
Anybody will give a patient who had an MI yesterday NSAIDs? No. Nobody gives anybody who had an MI yesterday NSAIDs. Okay? Do not give them NSAIDs, anybody with MI. So how do you treat an acute inflammatory process?
Cortisol.
No. You don't give that, cortisol, or you don't give NSAIDs. So what else do you give? What's that? No, nitroglycerin, he has stenosis. Pericarditis. So pericarditis next post to mine. So yes, we have pericarditis. This is a specific type, very common, very common. Not popular in books, very common practice. Every time. If anybody who's gone around is going to see it. So what do you give? What's the treatment?
Diuretic.
Diuretic is for heart failure. You're not going to dilate the inflammation. How are you going to reduce the inflammation? So what happens is the myocardial infarction is an acute inflammatory process. Revascularization causes revascularization injury, and there is an acute inflammatory process. How do you reduce that when it's related to the pericardium? What do you give? No, not an allergy. Antioxidants is for a long time benefit. Aspirin. Correct. You give high dose aspirin. So instead of giving the normal 81 milligram aspirin, you give 600 milligrams of aspirin 3 times a day to curb the chest pain. That's the treatment. Yeah.
Isn't it an NSAID?
No. Very different. So in the world, so when you read it in the book, in the pharmacological book, it looks the same. In treatment, in life, when you are dealing with patients, COX-1 and COX-2 are very different. Aspirin has very different stuff than NSAIDs. NSAIDs are very bad, very dangerous drugs. Very bad for vascular disease, very bad for kidney. Aspirin is something we give very frequently to these patients. Okay? So they're very different. They all reduce inflammation, but use very different. Now, if we talk about pericarditis, the normal pericarditis. So, for example, 35-year-old patient, no medical history. Yesterday didn't have an MI, the day before he didn't have he had nothing. He was walking, had a viral infection, treated 1 week ago. He walks in, he has positional chest pain. You think it's pericarditis. What will be the treatment for this patient? Not aspirin. This is the patient, you give them NSAIDs. So we talk about when is NSAIDs important is a case like acute pericarditis in the normal setting. Patient comes in, chest pain, he is pericarditis. Diagnosis pericarditis. normal pericarditis, post-viral, the idiopathic one. This you give high dose NSAIDs for 2 weeks. Okay? If you go to a patient who is 70-year-old, he has chronic kidney disease, and you give him NSAIDs, you're going to have proceed with this patient going to dialysis. But if you give him aspirin, nothing's going to happen. It's very distant. Okay? Treatment for pericarditis, normal pericarditis. The pericarditis you see every day is 3 things. One, you deal with inflammation. What do you do with inflammation? NSAIDs. This is normal pericarditis. This is not post-amide. This is the normal pericarditis. Emergency room. Walks in the emergency room, had viral infection 3 weeks ago, no MI. So NSAIDs contraindicated in MI. Acute coronary syndrome, congestive heart failure, chronic kidney disease. This patient has none of those stuff. He's a normal, healthy guy by pericarditis. Okay? It's common in the years 30s, 25, 40, and has pericarditis. So we treat him with 3 things. One is high dose NSAIDs. It's always going to be high dose. Okay? High dose NSAIDs. Usually if you had a headache, you get ibuprofen 200 milligrams. Okay? If you have this pericarditis, the treatment is going to be 600 milligrams 3 times a day for 2 weeks. So high dose. Number 1. Number 2 is what? Colchicine. Oh. Okay, so pericarditis, inflammation of the pericardium. You decrease the inflammation with NSAIDs. The second thing is you want to reduce recurrence. You want to reduce the recurrence of the pericarditis. So what you give? Colchicine. Colchicine. Colchicine is much more used for pericarditis than for gout. Okay? Colchicine. You give colchicine for 3 months to reduce pericarditis, another episode of pericarditis. And the third thing is counseling. No contact sports for 3 months. Okay? No contact sports for 3 months. So no contact sports for 3 months. Treat the acute inflammation for 2 weeks with high dose NSAIDs, and then you reduce the recurrence with what? Colchicine. The recurrence of pericarditis. Yes?
What does colchicine do?
Okay. So colchicine is an anti-inflammation, inflammatory drug of some sort, which we have no idea how the hell it works. No idea. Okay? And now, colchicine is a very weird drug. You look at the mechanism of action, has nothing to do with the clinical benefit we see. We do the clinical trial. So in clinical medicine, we do the clinical trial. The clinical trial shows benefit. You give the benefit. So the clinical trial is an iconic clinical trial that showed when you give colchicine for 3 months for patients with pericarditis versus patients with no colchicine, there's decrease the recurrence of pericarditis. So you get it. Okay? All right. Of course, in pericarditis you can have other things. You can have like malaise, fevers, dyspnea. But the most important thing is chest pain, which is positional in nature. Okay, so what's the most specific physical finding? No, physical exam. We do physical exam. So history is by far the most important thing is history. Okay, but the physical exam, what did you find which is specific by auscultation? Friction rod is a very famous, important clinical exam finding, and you read in the book, is a very useless clinical thing. Useless.
What is it?
It's called a friction rub. You hear the friction, the pericardium hits the parietal and hits the heart, the myocardium, and then you hear a friction rub. Scratchy in nature. Most of the times, 95% of the time, somebody reports to me that the patient has a friction rub. It's an imaginary friction rub. Okay? So it's something you always hear about, but it's usually not clinically relevant. Clinically relevant is the patient comes in, he has positional chest pain. That's real. That's real. That's why you make the diagnosis. Okay? Now, fever, chest pain, other things, physical exam. If the patient's tachycardic, sinus tachycardia is a marker that the heart has a problem with something. Sinus tachycardia. So if you have pericarditis, you have sinus tachycardia. If you have acute myocardial infarction, you have sinus tachycardia. If you have a pulmonary embolism, you have sinus tachycardia. Aortic dissection, you have sinus tachycardia. What's the common thing in all these? They are serious diseases. Okay? So serious diseases, you can have sinus tachycardia. As a marker of sinus disease, it's not really specific though. Most important thing is after physical exam. So physical exam, you have history, physical exam. History is number one. Number two is ECG. So we have ST elevation, widespread, all over the pericardium, and you will have PR depression. So ST elevations, okay, and PR depression. This is very small stuff, very subtle. The most important thing when you look at an ECG with a patient with chest pain and ST elevation is make sure that it's what? Not a myocardial infarction. I don't want you to think this is systemic pericarditis. That is a disaster. If you have a STEMI, what's the mortality rate? 50% before they reach the hospital. 50% STEMI. Pericarditis doesn't exceed 0.1%. Very two different diseases. If the patient had an ECG done in the waiting area in a random place in the ER, and you see ST elevations, he's a 35-year-old smoker, you think he's fine, and then you do the ECG, and then you find ST elevation. What will you do? Yeah, you're going to take the patient and move him to the trauma center, to the resuscitation center. You don't keep him lying around there, in the middle of nowhere. Why? Because we know this patient at any time could die from what? Ventricular fibrillation. People with STEMIs die from VFib, ventricular fibrillation. When you have ventricular fibrillation, okay, when this happens, you have a mortality that increase 10% per minute. 10% per minute. Meaning you have VFib now, 1 minute, 90%, 2 minutes, 80%, 10 minutes, less than 1% survival. So VFib means you have to act very fast. Acute myocardial infarction. Why do we take it seriously? Because we want to put the patient in a place that if you have VFib, you can defibrillate. The mortality of STEMI goes down from 50% to 5% because we have this ability to do this. Okay? So what we don't want to do, we don't want to confuse pericarditis with myocardial infarction. Okay, so we look at this ECG. What is this? So ST elevation, ST elevation, ST elevation, all diffuse ST elevations. Okay? And you can see some PR depression here. So what's the diagnosis here? So first of all, what's the rate? Yeah. Go.
What is more than 140?
Okay, so how to calculate the rate? 300 and this, no. So when you're confused, when you come to the exam and you're confused, if you have AFib, how do you calculate them? This always happens. In an exam, they come and say, we can divide 300, 400, and then when they come to AFib,
10 seconds.
now what you do, this is a 10-second strip, meaning this ECG, all the time, whenever you see this pink one, from here to here, it's always 10 seconds. This is 10 seconds. 1 minute, oddly enough, has 6 10 seconds. 1 minute is 60 seconds. So 6 of these. So what you do, you basically, very fundamentally, just count these 1, 2, 3, 4, 5, 6, 22. And then you multiply it by 6. If it's AFib, if it's sinus, doesn't matter. You do that, and that's it. Easy to remember. Okay? Okay, so this is about 120, so second is tachycardia. ST elevation, there's some ST PR depression, so this is pericarditis. Okay, that's fine. Again, ST elevations here, PR depression. What do you guys think? Pericarditis, okay. How about this one? What's the diagnosis here?
Anterior MI.
Anterior myocardial infarction, STEM. Okay. Why?
Only in some of
So you see Q waves. So ST elevations, this is Q wave, as ST elevation, and then one place, anterior septal, anterior lateral, so anterior septal. So this is anterior stem, okay? It's not pericarditis. Now if you look here, you can have some subtle ST depressions here. So this is subtle ST depression. So this also gives you better indication this is MI. But the most important thing here is to notice the Q wave. This is a Q wave. Going down, up. All right? Let's see about this one. What do you think about this one? What do you think about this? Anterior stem, Y. Q. Uh-huh. Yeah, okay. So this is the ECG I want you to look at. This is pericarditis. This is pericarditis. Why? So pericarditis is confused. But why is this pericarditis? What is this thing that's down there? So there's PR depression. But what I worry about, what is the thing that makes you worry that this is MI? What do you worry about? You worry about what? Q wave. Here, you worry about this. Q wave. Why is it not a Q wave? Why is the deflection in V2 not a Q wave?
Maybe because it's posterior.
Because it's after an hour.
Because it is after an R wave. You first started going up here and then goes down. So this is not a Q wave. Not a Q wave. So there's not a Q wave and diffuses the elevations, and you can see here some PR depression here, and probably a little bit here, but this is pericarditis. Okay?
What's not acute?
Not a Q wave, because here it starts with an A. Something goes up first, then goes down. If you look at the previous one,
Like lead one. So is there a Q wave on lead one, doctor? There's a small depression.
how to go back. All right. So here, this is a Q wave. Okay? This is very important because it's very confusing. Here is a Q wave. Goes down, and then up. Goes down, then up. This is a Q wave. Okay? Starts, first deflection going down. Here, first deflection going up, then goes down. So there's not Q wave, there's S wave. All you guys got that? All right. Okay. What about this? What's the diagnosis here? What's that? It's tombstoning. So severe ST anteromyocardial, massive anteromyocardial infarction, massive myocardial infarction. ST elevations here, and then very clear reciprocal ST depression. When you see ST elevation in one area and ST depression in another area, this is an MI. This is STEMI, no question. Call the captain. Okay? So what's our investigation you want to do for pericarditis? ECG, X-ray, and echo. You want to do CPC, you look for leukocytosis and ESR, CRP. You look for secondary cause, hypothyroidism, uremia, this is the renal function. And sometimes you can do a PPD test, some people do that. Look for sign inflammation. Okay, you can have pericardial effusion, a chest X-ray, a large chest X-ray. For you to see it, you'll probably need 200 cc's of effusion. So one of the complications of pericarditis is pericardial effusion. It's rare, but when pericardial effusion happens, it could be a problem. If pericardial effusion becomes tamponade, okay? You have a pericardial effusion. When the pericardial effusion causes tamponade, it's dangerous. Usually pericarditis by itself is very painful, is very annoying, but low mortality. If pericardial effusion, shortness of breath, then it's something that could potentially be very life-threatening. So we talked about the management, no competitive for 3 months, and NSAIDs for 3 months, NSAIDs for 2 weeks, and colchicine for 3 months for decreased recurrence. Now, when do you do prednisone immunosuppressive therapy? If you fail, if you give NSAIDs and then you give colchicine for 3 months and recurrence, and then you treat again and then you fail, and then recurrence, 2, 3, 4 times, then you start prednisone. Try prednisone. If the prednisone you try it doesn't work, then you try methotrexate and other weird things. Okay? But this is not the first presentation. The first presentation, you give them high dose NSAIDs and then you give them colchicine. Okay? If that doesn't work, multiple recurrence, then you can do other treatments. So pericardial effusion is fluid in the pericardial sac. It could be transudate, it could be exudate, it could be bloody, it could be from trauma, chyle. This is an example of bloody pericardial effusion, hemopericardium. We see it in autopsy, but the patient died. It was a bad thing. dissection with fluid, with blood in the pericardium is a bad thing. You usually can't drain it. And now, the effusion, what happens is depending on the fluid, how fast it accumulates, the body is able to accommodate it. For example, if you have cancer, most common cause of pericardial effusion is cancer. That's what most of the times you see. Cancer, some sort, irritates the pericardium, starts producing fluids, accumulates over months before you can have a tamponade. Okay, maybe you never have it. If you do a PCI, and then during your PCI, you puncture one of the coronary vessels, dissect it, and then blood goes to the pericardium, 50 cc's is enough to cause tamponade. Okay? Two very different things. Yeah.
Can heart failure be disclosed to effusion, pericardial effusion?
What's that?
Heart failure can cause pericardial effusion?
No, usually no. Usually not. They're different. Heart failure, so congestive heart failure with pulmonary edema is edema coming out of the you have left ventricular pressure, elevated left ventricular pressure, and diastolic pressure. The blood from the ventricle cannot go back to the heart, so it goes to interstitial. That's pulmonary edema. Okay, very different. Okay, so the most important point I want everybody here today to know: when and how, by physical exam, you can tell me a patient has tamponade. What do you do on physical exam that you can know the patient has tamponade?
I think you don't hear anything when you try to auscultate the because of acid fluid
Tell what it is. What do you look for? So what do you do physical exam, and this is tamponade? JVP is elevated. What else?
Auscultation.
Okay.
Echo.
What? No. Physical exam.
Yeah.
Stethoscope, hands, looking at the patient, seeing the patient. So you see JVP is elevated. What else?
Don't sound the scope maybe.
Okay. Two things, two opposing things. So if somebody comes to me in the ER and I see elevated JVP, what do I expect the patient? What's the most likely diagnosis? Heart failure, congestive heart failure. What do you hear by auscultation when you have a patient with congestive heart failure? What's that? What do you hear with your stethoscope when you put it on the lungs of a patient with heart failure? What do you hear? Crackles. You can hear crackles. Fluids in the lungs. You hear it when you put the stethoscope. JVP elevated, crackles. That's congestive heart failure. But if the patient who you think has heart failure, he's sick, hypotensive, tachycardia, looks like really bad, JVP is elevated, and then you put the stethoscope and there is no crackles, that's tamponade. Elevated JVP, clear lungs. Elevated JVP, clear lungs. Sick patient, hypotensive, blood pressure 80/40, tachycardic 120 beats per minute, looks bad, looks sick. You examine JVPs all over here. You listen to his lungs and you hear there is no crackles. You expect him to be very congested, but he's absolutely not congested, but very sick. So this patient has what? Tamponade. So what are the findings of tamponade physical exam? Elevated JVP with clear lungs. That's tamponade. Okay? Now Now you could have, so if you have fluid around the pericardium, you'll have muffled, muffled sound, but that's not specific. I don't care about that. That's not something you really can say. What you can really say with the JVP is pound the JVP up to here, and then the lungs are clear. That's clear. That's very specific, very diagnostic. What you do, what's your next step?
Echo.
Emergency echo. Emergency echo. Because what's the treatment? Needle pericardial synthesis. So you insert the needle, take a fluid out. Quickly. Because the next couple of hours the patient could die. Hypotensive, then he holds, and then that's it. Okay? So it's a very different thing. You can have pericardial effusion for months. There are some patients we follow these effusions for years. But it's only a problem when it's tamponade. What happens in tamponade? What's the pathophysiology? What actually happens? The intrapericardial pressure in the pericardium is higher than the pressure in the right ventricle in the ascending. That's what happens. So the chambers of the heart, the right side and the left side, we have systolic pressure and diastolic pressure. Okay? Diastolic pressure is what opens the ventricles. They open in the diastole. And they're open because there's pressure inside to keep them open. If the pericardium, pressure in the pericardium is higher than the pressure in the right side, the right is lower than the left, right? So the pressure in the pericardial space is higher than the right side, the right side collapses in the diastole. Collapse in the diastole, blood cannot be pushed from the right side of the heart to the lungs. That's why you don't have clot. Because you don't have fluid, blood going to the lungs. You have low cardiac output. Patient is sick, patient is dizzy, patient feels tired, he's dyspneic, he's very sick. Low cardiac output. Because the right ventricle cannot expand because the pressure in the pericardial fluid is higher than the pressure in the diastolic pressure on the right side. So it collapses, and that's what you see in echo. But the diagnosis is clinical. I could see right free collapse, but no tamponade. That's fine. It's a clinical diagnosis. I see the patient. The patient looks sick, hypotensive, dyspneic, tachycardia. And then by physical exam, I see other findings, and then that's suggested. One of the other important findings we see in pericardial tamponade is pulsus paradoxus. What's pulsus paradoxus? What's pulsus paradoxus?
It is when the blood pressure changes when the patient is breathe in and breathe out.
Correct. So changes in blood pressure with inspiration, expiration. Okay? So how do you measure that? What you do is you put a blood count. You put a blood pressure count. Okay? And you start measuring. When you start measuring, you will notice that the first sound you hear, the first protocol sound is intermittent. Meaning it comes and goes, it comes and goes, it comes and goes. So you record that first sound, the one that goes, comes and goes, the intermittent one. And then you continue to deflate till you hear the sound constant. Doesn't come and go, it's always there. The difference between those two is your pulsus paradoxus. Okay? So there's two reasons to have pulsus paradoxus. Pulsus paradoxus is what happens when there is increased interventricular interdependence. Everybody has ventricular interdependence, but when you have increased interventricular interdependence, because you have fluids shoving the ventricles together, then the difference between inspiration and expiration that's exaggerated. And that's why I have pulses. Okay? This is how it looks like in the ECG. These pulses are alternate. This is flow, the earth. Okay, and this is what we talked about in echo. You see the right ventricle collapse in diastole. Okay, I don't want anybody to say systolic RV collapse because everybody here has systolic collapse. Systolic collapse is normal. Systole means collapse, like this. But when there's collapse, diastole, that's something. Okay? So, systole is normal, but there's contraction on the right and left side of the heart. But if there's contraction during diastole in the right ventricle during with pericardial effusion, then that's tamponade. Pericardial disease is the treatment. So, constrictive pericarditis is a different entity. Constrictive pericarditis usually is not about fluid. Constrictive pericarditis is the pericardium itself becomes very calcified and very rigid. And it causes over many months and years that the ventricle cannot expand normally, like it does. So tamponade, it's an emergency, it happens in the ER, it happens right now. Constriction is not fluid, the pericardium itself being very hard, it happens over a long period of time. Okay? So that's what happens. So why does tamponade happens? So if you have an infection, TB, viral infection, sarcoidosis, all can affect it. Sometimes if you have cancer that affects it, can cause it. Radiation therapy, if you have surgeries, can cause it. Transplant can cause it as well. But it's a long process. Okay, that's and present with right side heart failure. So you have radiation or edema or pivot, that's an infection. Okay? It's a very complex disease, very difficult to make the diagnosis. Okay, usually by cath or echo. Treatment is usually very complex. What they do is they try to peel it. See, here is very calcified, lots of calcifications. So what the treatment is you trying to peel the pericardium. So they try to peel it. That's what happens. Very complex surgery, variable rates of success. Physical exam, the most important one is the cosmal sign. So cosmal sign, usually JVP falls inspiration. But in patients with pericardial, constrictive pericardium, the opposite happens. So the JVP with inspiration increases. Okay? Right. So what other very important sign that has cosmal? So one is constriction. What's the more important one?
I think just stay with your line supine position, maybe.
What's that?
When your line supine position, the pain becomes worse, maybe.
The what?
The pain becomes worse in your line supine position.
I'm talking about cosmal sign. Cosmal sign, you look at the JVP. The JVP usually, in most patients, when you take a deep inspiration, the JVP goes down. Okay? In inspiration. But in these patients, with inspiration, it floats. That's cosmal sign. It happens in constrictive pericarditis, but it also happens in another very important disease, is when you have a right ventricular failure, RV failure, second ventricular. You have inferior stemming, RV failure. Cosmal sign. And it's important because you don't want to get these guys nice. Okay? nitrous. Artery failure, don't want to do nitrous. Okay? Questions? So this is the treatment. You take it piece by piece. Any questions? Yes?
Doctor, you said we peel off the pericard.
Yeah,
the
that's what,
pericardium.
yeah.
The area which become empty, what do we do with it? Like نحن مو نحن أخذنا البريكارديوم.
Okay.
يعني الاريا اللي ضلت.
ما مهمة. People sometimes have congenital absence of pericardium. Not that important. Questions? Email. Any other questions? Yeah.
We see cosmal signs about cosmal breathing.
What's that?
Cosmal breathing. Heavy breathing.
Okay. Those different things. Plasma sign is J. All right. One more.
Can we keep one more time pericardial tamponade and pericarditis and regarding the
All right. So one more time. Congestive heart failure. 99% of the time you are in the emergency room with a patient who has shortness of breath, is congestive heart failure. Okay? Especially when JVP is elevated. Well, how does heart failure happen? The blood comes from the right side of the heart, the body, the right side of the heart, goes to the lungs, tries to get back to the left side. When it tries to get back to the left side is not moving appropriately. So the blood backs up in the lungs and spills to the lungs. It also backsides to the right heart and have JVP. So right heart causes JVP and left heart causes lungs. That's congestive heart failure. If you have tamponade, what happens in tamponade, the blood goes to the right side of the heart and can't go to the left of the lungs. It's stuck in the right side. Why? Because the right ventricle is squished. So it can't expand to accommodate. It's squished by the fluids. That's what happens. So you have JVP because all the blood's trying to go to the right side, JVP is related, but you don't have congestion because no blood going to the left side. Okay? All right. Thank you.